It's 2 o'clock now, isn't it? So, welcome to everyone to Thurrock's Health and Wellbeing Board meeting for September. I probably it might be worth just going around the room very quickly introducing ourselves because some people will be very new to us here. So, if I go that way, so obviously I'm Mark Hooper, I'm the chair.
Good afternoon, everybody. I'm Rob Percy, Executive Director for Adults and Health at the Council.
I'm Councillor Lynn Worrell, Leader of the Council.
Hi, good afternoon. I'm Councillor Vicky Hartstein. I'm Cabinet Member for Children's Services, Education and Community Safety.
Hello, I'm Councillor Lizzie Rigby. I'm Shadow Portfolio Holder for Health and Wellbeing.
Hi everyone, I'm Harper Lodgler. I'm Assistant Director of Public Health / Consultant in Public Health.
Hello, I'm Tina Russell. I'm Deputy Director for NELFT and I'm here to represent Jill Burns.
Hi, I'm Mark Graver. I'm Head of Public Affairs at ePut and I'm here to represent Matt Borrelli.
Hi, I'm Mark Tebbs. I'm the Chief Exec of Thurrock CVS and sending apologies from Kim James from Healthwatch.
Hi everyone, Tom Abel, Chief Executive at Mid and South Essex Integrated Care Board.
Afternoon everyone, Margaret Allen, Deputy Alliance Director for Thurrock in the ICB.
Hi everyone, my name is Andrew Graham and I'm the Learning Disabilities Health Equalities Commissioner for the South End Essex and Thurrock Learning Disabilities and Autism Health Equalities team.
Afternoon, Scott Edgerton from Essex, please.
Hi, Michael Deneen, Assistant Director for Community Protection and Enforcement.
Gloria Godaro, Chief Officer for Housing, Economic Development, Skills and Regeneration for the Council.
Welcome to everybody. Before I do the housekeeping, have we got any apologies today?
Nothing in addition to what's on there.
No? Okay. Right, so a bit of housekeeping then. It's an in-person meeting, so thank you for being here. The meeting will be recorded as it is and live streamed as it is an official council meeting. Now, to keep me on track, we'll continue to use a flagging system, giving you two minutes notice in terms of your presentation coming to an end or a period of time for questions. Otherwise, I'll let you speak forever. But obviously, there's a little bit of leeway within that. Okay. Please sit in your allocated seats. Don't move around because obviously when it comes to you, I don't want Mike to become Gloria when we're on the live stream. I don't think we've got any guests today. Right, in terms of the mics, obviously turn them off when you're finished speaking and turn them on when you are. I'm not expecting any fire drills today, so if the alarms go off, it's probably the real thing, and we'll be escorted out of the building by the officers present today. Right, so the only apologies I actually did have were from Jim Nichols, Alex Green and Sharon.
Kim.
Sorry?
And Kim.
And Kim, right, thank you. Right. Right, so I'll move on to June's board meeting, which is on page 5 of today's papers. There were a couple of actions from the board meeting, which was the establishment of the JSNA, which is on the agenda today, and board members to send recommendations regarding kind of agenda issues for the JSNA, which I believe was done. Are there any other issues from the notes on June's meeting? So that being the case, can we agree that they're an accurate record of the meeting that took place in June? I've not agreed to any urgent items of business. And item 4, any kind of declarations of interest that people wish to make. I take that as a no. Right, okay, then we move on to the substantial items on the agenda, which is the ICB kind of reorganisation. Now we've got 20 minutes for this. Well, 10 minutes of it's just 10 minutes of presentation from Tom, I believe. Is that right?
Yeah, happy to. And I think what we're hoping to do is, I think Rob, you're going to pick up on item 7, because I think the two pieces obviously do interrelate with one another. So thank you for the time this afternoon. I think hopefully, as all members are aware, a number of months ago the government announced that there would be some significant changes to integrated care boards in England. The headline was to secure a significant reduction in the running costs of ICB, so a 50% reduction in ICB running costs, alongside a refocusing of the role of integrated care boards, moving towards what's being described as becoming strategic commissioning organisations, and moving away from, I think, some of the sort of blurred accountabilities that there have been within the health service between ICBs and NHS provider organisations. And that was part of a package of changes also linked into the abolition of NHS England and the reabsorption of NHS England back into the Department of Health and Social Care, and a refocusing of the role of NHS England in the future as well. So obviously that was announced, and then alongside that we also saw the publication of the NHS 10-year plan, which sets out the government's ambition for how NHS services in particular will be improved over the medium term, which equally also helped in terms of clarifying our role and our responsibility as an integrated care board, particularly around taking the necessary steps to recommission NHS services so they are more sustainable and deliver better access and outcomes for local residents, but secondly building the neighbourhood health service, and so putting in place the arrangements in terms of being able to deliver greater place-based care, greater neighbourhood-based care, with the ambition of moving services from hospital and acute settings into local communities. Locally, here in the east of England, kind of the first key kind of decision that was made was that we didn't feel that we'd be able to continue to operate 6 ICBs in the east of England, and agreement was reached to move from 6 ICBs to 3 ICBs, those being Essex, bringing together Mid and South Essex Integrated Care Board with North East Essex, which is currently part of Suffolk and North East Essex, alongside West Essex, and so there'll be an Essex ICB. The other 2 will be Norfolk and Suffolk ICB, and the third will be what's being described as Central East ICB, so that will bring together Hertfordshire, Cambridgeshire and Peterborough, and Bedfordshire, Luton and Milton Keynes. We've had confirmation last week through a ministerial statement that the formal creation of those organisations will occur on the 1st of April. So the new statutory organisations will exist from the 1st of April next year. And so in the meantime, we are moving towards the necessary transitional arrangements to support the move from the current 6 ICBs to the 3 ICBs. So locally, here in Essex, there has been the announcement of the designate chair of that new ICB, so that is Paul Burstow, who's currently chair at Herts and West Essex Integrated Care Board. Paul will take on the chairmanship of Mid and South Essex ICB also from the 1st of October, so Mike Thorne will be stepping away at that time. Secondly, progress is being made around the appointment of the designate chief exec and executive appointments, and we hope to be able to confirm those by the end of the month. There's a desire with some of those announcements to do them on a national basis, so although we're very much on track in the east of England, there's a bit more work in some other parts of the country which needs to resolve, so we can confirm that. And then thirdly, we are just working through the transitional governance arrangements which will be considered by the Mid and South Essex Board at our meeting on Thursday. But the aim is to set those up from the 1st of October. What that's likely to look like is the creation of a joint committee between Mid and South Essex, Suffolk and North East Essex, and Herts and West Essex, to which the commissioning responsibilities for Essex will be all delegated into the same place. So we can start to make the necessary plans in terms of the shape of health services from next April onwards. There's, I guess, some specific things which it'd be worth drawing the committee's attention to. So clearly one of those is the future of place-based and neighbourhood care arrangements. So we've clearly got excellent alliances here in Thurrock and elsewhere across Essex. We want to make sure that in this transition we don't lose any of the momentum and the good work that's going on in that space. However, we do know that the direction is for the ICB to move towards the commissioning of those arrangements as opposed to the direct kind of delivery and getting directly involved in the provision of those arrangements. And so we need to do work together on that to make sure we preserve all the good stuff that's going on at the moment. And equally, obviously, there's clearly an opportunity with local government reform as well to think about what can we do to bring our work together with local authority colleagues. And then more strategically, I also think there is significant opportunity in terms of thinking about some of our commissioning activities that we do within the ICB, again, where there's join up potentially with local authority colleagues and think about what we can do also to bring that together as well. We are waiting for some further guidance and a further detail about some of the things that were set out that the ICBs would not be doing in the future. So people may be aware there's some debate in terms of the future of how continuing healthcare services will operate in the new world. Equally, also alongside some of the responsibilities that ICBs hold around areas like safeguarding and special education and needs. I think in the first instance, I think there's going to be very little change to those arrangements, which I think is probably a good thing to make sure that we keep that stable. But it will be something we'll want to engage and talk about as it becomes a bit clearer in terms of what the future shape and approach that's going to be nationally. So I hope that's helpful. Obviously happy to take any questions. Do appreciate all the support that council colleagues have shown to everybody within the ICB as we've gone through this, because clearly it is a significant change and it does impact people. We're doing our very best to keep the team in the ICB informed and engaged, but I don't think you can get away from this as not being an ideal process, and something we're going to need to make sure that we stay focused on so we don't lose momentum in the work that we're doing at the moment. But I'll pause there, Mark. Happy to take any questions.
Mark.
Yeah, I just wonder whether there's any clarity around the intentions for kind of patient engagement. Obviously there was an announcement that Healthwatch England is going to be dissolved as kind of part of this process. I wonder whether there's any local thoughts around how we ensure that voice is heard.
Yes, so I don't think we've got any advanced thoughts, Mark. What I'm hoping we can do is, as once we get through this month with the designate announcements, is to start to have a conversation with you and also colleagues in Southend and Essex around what can we do together to make sure that we don't lose the public's voice and community's voice in the way that we commission services. And because there is a risk that we lose that, which obviously would not be the best thing for anybody. So I'm hopeful once we kind of get through this month, we can start to have a conversation about what does the future look like, what can we do working together with you and others to preserve what we can to make sure that that voice is clear and present in all of the future commissioning decisions that we make.
I have a few questions, no surprise. In terms of partnership working with the council, how will these changes affect that current partnership? Because it's been a real strength of the council to have those partnerships.
So I think in the first instance, we won't. The existing partnerships will exist in their current form. We're not going to be getting rid of any of the current mechanisms that we've got in place in the first instance. The thing that we'll need to work through, and we'll do this together, is if you read the 10-year plan, the 10-year plan sets out this ambition to create what's called integrated health organisations. And so these would be organisations which are responsible for the delivery of care in a local area. And so, and the ICB would commission those organisations to provide care. Now, my aim and my hope would be that we would be able to integrate our commissioning between councils and the NHS, and so actually we can commission those services in a way that they are holistic and address all of the various factors that affect people's health and well-being in a joined-up way, as opposed to sort of the NHS doing something completely separate to local authority colleagues. And so, so I think no immediate change, but we will need to work together to think about what do these changes in the NHS architecture mean, and how do we work best together to make sure we join up and we don't see a separation as a result as we go through the change.
Okay, I'm glad to hear that. I'm particularly keen to promote partnership working across the hospital trust, NELF, yourselves, and EPUT, because I think it'd be good to have that kind of joined up thinking rather than almost like feels like people have got like 3 or 4 different plans which is not entirely joined up. And I think that makes complete sense. So that's something I'll certainly be working on with Rob over the next few months. In terms of, we're doing some work trying to look at the buildings that we need for our healthcare provision in Thurrock, or the Thurrock area. Will that work continue, or because I know that maybe the ICB aren't necessarily responsible for buildings?
Yes. So the work will continue again in the first instance. Obviously, I know there's been various frustrations, hasn't there, in terms of us being able to get some of the delivery at pace that we would all want around the improvement of healthcare estate in Thurrock particularly. The way I think will evolve is it will move. So again, the ICB, rather than delivering projects and being responsible for the delivery of projects, we will be setting out our expectations in terms of this is the estate we believe is needed to serve this community effectively, and then working with providers and property services in the case of NHS, some parts of the NHS owned estate, about how do we secure that. So they will be responsible for delivering that. So we'll have more of a planning kind of capability and function as opposed to a kind of a delivery function in the future. I'm very keen, and I've fed this up the line. I know that NHS Property Services has not been the most responsive organisation, as Margaret will probably tell you much better than me. And so we do need a change there too, in terms of the way that NHS Property Services operates. But for colleagues who don't know, so quite a significant proportion of kind of community healthcare estate is owned by an organisation called NHS Property Services. It's effectively a wholly owned company of the Department of Health and Social Care. But as a result of that, it can feel a bit distant, and it isn't necessarily as responsive as I think we'd all want it to be.
Rob?
So can I just come in and try, if I forget to get this bit, try and get me to the end to close the loop on this circle, because I just wanted to come in to bring that point in. So just around all of this at the moment, just to stress from a local government reorganisation point of view, if I could do that bit, just so everyone's aware, local government reorganisation is timing a little bit behind the ICB. So the ICB is next May. We are a priority programme in Essex, but it's likely to be 2028 that LGR is in place. It's not here to go to the models, but where Thurrock went public a couple of weeks ago with the I'm conscious I was sitting here between the chair and the lead. I better get this right, haven't I? You know, we're looking at we're promoting a 4 model, because the LGR purpose is to move from a 2-tier council system to single-tier authorities. There are models of 3, 4, and 5. We're supportive of a 4 single-tier authority model in Essex. That decision will not be taken until early next year. In the meantime, though, from a health and social care point of view, just to stress that over this summer, Essex County Council, Southend and Thurrock have all been inspected by the Care Quality Commission for Adult and Social Care Services. We have all received a good, and in Thurrock we received a really strong good, and that's really positive for all of us. It's going to help us all work together, and we are working closely. I've had meetings with Tom a few weeks ago around some of this. I'm going to mention a meeting that Margaret I've just been in before this meeting today in a second. One of the things that the three councils are doing, just so you know now, is we're beginning to map exactly what the challenges and issues are going to be, whatever the model is, around our statutory responsibilities for social care, and how we deliver those to the people with the greatest needs, around our commissioning arrangements, and around the financial arrangements. The market management is going to be really challenging, whatever model this looks like, and it's important to do the thinking now, and we're engaging the ICB and health colleagues in that planning now. Now, we got the good, and we got a very strong good. I just want to stress, one of the reasons we got a strong good is scored under 9 domains, the inspection, and one of those domains we scored a 4, so we scored an outstanding, and that was on partnerships and communities. So it's worth stressing that in the context of your question, Councillor, and Tom's response. We are seen as an exemplar by the Care Quality Commission and others for our integrated approach to working, how it's been established over a number of years, and how that's delivering for the patients in terms of receiving upstreamed interventions in both health and social care. So to Tom's point, it's really important that we continue that journey, and we are going to be very ambitious to maintain staying ahead of the game on that as we go forward. So what we're doing is very much in that space of the neighbourhood health journey already, and we've got an ambition to pursue that. On the facilities, and you just mentioned the buildings, we have just met before this meeting around establishing we're going to call it a health regeneration working group. And we met today, Margaret from the ICB, myself chairing the meeting from the council with planning and regeneration colleagues. We are looking to prepare, so the ambition will be to prepare an NHS estate strategy for Thurrock. So without going into the details here, that's what it will be. We'll kind of address the neighbourhood approach to providing integrated facilities on the neighbourhood level, take into context what Tom just mentioned about that. It'll also look at the future of the hospital, which will build on a meeting that we had yesterday with the hospital, and we'll be coming to Mark and Tina. I'll be talking to Breed and to Alex about getting NELFT and EPUT representation to this meeting as well. And we've had a discussion about the need to importance of engaging NHS property services in that more actively. So I'll keep everyone engaged in communicating on this space. But we've had a really constructive first meeting just before this meeting today. And hopefully that closes the circle about the fact that we continue to work closely together. I think just finally, in what Tom's just said, there may be opportunities for us to look at how there will be opportunities for how we look to commission differently and work more collegiately across local authorities and the ICB to the benefit of fundamentally our patients, but in a more efficient way, our patient service users and communities, but fundamentally more efficiently working to the strengths that the ICB has and the council has in different areas.
Thank you. Is it Mark?
Yeah, could I just add, the Essex CVSs have been meeting for the last 6 months with Essex Community Foundation, just to, because as a collective we probably represent kind of 3,000 or 4,000 community and voluntary sector groups across Essex, and we've kind of put out a couple of press statements, just kind of setting out, almost like whatever the option is with LGR, with NHS reconfigurations, with bigger footprints, it's really important that we get the voice of community and voluntary sector through that kind of process. So that statement kind of sets out an offer of kind of a desire that we kind of set up a task force that really focuses on the community and voluntary sector, and that we really try to do two things with that. Kind of like I think the community and voluntary sector really feel that the transition arrangements create lots of risk for us, so we kind of want to make sure that we manage that risk, and I think doing that collectively and standardising that across Essex, there's a huge opportunity there. But also I think we we could use that task force to really make sure that we get the voice of the communities and those 4,000 members kind of into that process. So yeah, I hope, so we've kind of written a press statement, it's hopefully gone to the people it needs to in this room, but I hope that that offer is kind of taken up, because I think it'd be a really additional and an important part of the process.
Thank you, Mark. Unless there's Councillor Rigby.
Thank you, Chair. Thank you. Just following on with your neighbourhood teams coming in, we had the meeting yesterday that Rob alluded to. We talked about the financial aspect of moving from acute to prevention. Do you have any models on how it's going to work? Because we hear a lot about we are moving to prevention, but I've not actually seen much detail, and that would be quite interesting to see.
Yes, so there is modelling available, which kind of shows how, by undertaking better primary and secondary prevention, it obviously reduces utilisation of, hospital services and other NHS services as well. And I think, there's local examples, isn't there, Margaret, in terms of where we've taken action which has reduced downstream demand. So we can share some of those. The key challenge and tension, particularly when we talk about hospital services, is around how do you release the money that's being currently spent in those services so you can make the investment into the community. So for example, we may take an action as an ICB, which means that we're saving on average 2 beds at Basildon Hospital on a day-to-day basis as a result of that change. Actually, the hospital can't take 2 beds out of a ward and save the money. They have to take 24 beds out in order to actually release the costs associated with that. And so I think one of the things we'll need to work on is how do we commission at sufficient scale so it actually can release the value out, so we can make the investment in other parts of the health service. And so there's going to be this tension between what do we do at scale and all work on collectively to realise that benefit versus what might be some of the more sort of hyper-local priorities in particular communities, and get the balance right between the two. And so that we're going to need to do a bit more thinking together on that. But that's the approach I think we're going to be taking in the future, is that trying to get that balance to at scale things that will deliver value for taxpayers, release money which can be invested in prevention alongside the more sort of very local interventions in particular communities where there's particular needs that aren't being met at the moment.
So do you have sort of any idea what sort of time scale is to achieve a measurable difference in this plan?
So it depends on the topic we're looking at. So if we say look at CVD prevention, which I know is something that Thurrock's done very well at, and equally now if you look at so the principles from what happened in Thurrock have now been deployed more broadly across Mid and South Essex in general, and we've seen a really good improvement in terms of identification and management of people living with cardiovascular disease. We know, as a result of that, we've probably saved kind of over 100 strokes over the course of the past year. So some of these things are actually quite fast to realise. And so that's kind of things that sit in sort of the secondary prevention space. We have a huge opportunity with diabetes as well, that again, if we can better support people to manage their diabetes effectively, again, we should see a relatively fast impact of kind of utilisation of other parts of the health service in short order. And that's going to be what we're going to need to do in terms of our approach, is almost prioritise those things where we know there's a faster kind of payback, for want of a better description, on them, and that then releasing the investment so we can do some of the more fundamental prevention work together, which might have a slightly longer lead time in terms of seeing the benefits.
Okay, I'll take 2 more questions. I'm going to stop because I need to move on with the agenda. So I'll go Rob and then Margaret.
So this wasn't a question, but this was more to support Tom what I was saying, because I don't think we're in danger of having the discussion here, and I know it's a much broader discussion than one that a lot of us need to have yet. But just give you another example on building on what Tom's just mentioned. we touched on yesterday, and noticed Cherry coming through, sorry Cherry, but we touched on the potential for virtual wards, for example. So, I think Tom's absolutely right. The timing for this is going to be horses for courses. There are going to be some things we could do more quickly than others. But as far as getting some quick wins, the virtual ward concept, and I can explain that to people if they need to understand it, it's basically taking the acute hospital out into the community. So it operates in the community, in people's homes. That is a model which is already in place, which we could look to expand further and faster quite quickly, which have a real benefit in taking the acute and putting it into the community. So it just gives you another example. And then obviously we shouldn't possibly just mention the fact that is it next week the Community Diagnostic Centre opens, and the opportunity that has for kind of improving the diagnostics around cancer, etc. Quite quickly. It shouldn't be forgotten.
Thank you. Mine wasn't a question either, Councillor Rigby. Just wanted to put a footnote on what Tom was saying about diabetes and CVD. We have a rudimentary neighbourhood health plan already developed for Thurrock that we've been discussing for a number of weeks now with a range of clinicians in Thurrock, and both diabetes and CVD hypertension are both way up the list for action that the clinicians in Thurrock want to take forward at pace. So it will actually start to play itself out, I think even more strongly than Tom's already indicated.
Right. That being the case, I'll stop this agenda item there. Thank you for everyone's contribution. I know, Tom, you've got to shoot off, so feel free to leave. So thank you for coming today. And if I could then just move on to item 6, possible impact of NHS and devolution LGR reforms on local health and care system.
Just done that.
You've just done that, have you?
Covered that, yeah.
You've covered it already?
Yeah, cool.
We're ahead of time then. Did anyone ask any questions from what Rob said earlier? No? Okay. Then I will move on. So if I move on to item 7, air quality strategy. So I think the report is on page 11 of today's papers. We have about 20 minutes for this item, 10 minutes of presentation, 10 minutes of question, and I'd like Mike Deneen to present on this item, please.
Thank you very much, Chair. I'm not sure I'll take 10 minutes to present this item, but by all means, once I have introduced it, I'm happy to take any questions from yourself, Chair, and the board. So this is an update report regarding the progress of the All Essex Joint Air Quality Strategy. Since the Place Overview and Scrutiny Committee approved for Thurrock to work collaboratively with Essex County Council and Southend City Council, a public consultation has taken place. We've had good levels of engagement from the public, including those who reside in Thurrock. In July 2025, the chief execs from across Essex, that includes those within the districts, unanimously agreed on the draft strategy. So that now allows for councils involved to proceed with the relevant governance pathways, which includes us here at Thurrock. It is anticipated that the strategy will be published in autumn 2025. I think it's worth noting that this would then allow us to proceed with our statutory duty, which is to have an air quality strategy and action plan in place. So I look forward to that. Once this matter goes through the relevant governance, once adopted by Thurrock Council, we will therefore then create our own action plan, and that will be created with officers within my team and then in consultation with portfolio holders and naturally the Cabinet. If there's any other questions at the moment, I'm happy to take them.
Open to the floor.
Thanks, Chair, and thanks, Mike, for that. So this goes to scrutiny next, and then is this something that will go through full council? I'm just conscious that there's a big interest in air quality across Thurrock. With it, with indicators showing that depending where you live, air quality really does impact your life chances. So I'm just interested to see what the journey of this strategy is going to be through the council.
I'll speak with the governance team, Dem Services governance team, but my understanding is that it would go to scrutiny, go to Cabinet, and then potentially from there. So it's something that obviously the Cabinet and Place Scrutiny have already authorised us to proceed with, but that was under the proviso we bring back the draft because we weren't sure what it would look like. So the aim will be to pass through all levels of relevant governance, yeah.
Any other questions? Councillor Rigby.
Thank you, Chair. It's not really, I don't know if it's really a question as such, it's just I was actually quite surprised to see that the levels of nitrous oxide and particulate matter had actually fallen, because I know people are moving more to electric cars, but the vast majority of heavy goods vehicles are diesel. So that seemed quite a surprise to me. Do you think that that will continue, or especially with maybe potential Dartford crossing and things, we're going to have another uptick? Or, and also, I don't want to sort of question your data, but were there sort of, when going back sort of 10 years ago, were there sort of way it was measured the same as they are now, just to sort of ensure that that's accurate? Thank you.
I will come back to the board on the levels and the changes in testing. What I can't guarantee, it's always been out in the open via swabs, via collection devices. What I can't tell you is if scientifically that has improved immensely over the last decade. Like anything in science, I imagine it has, but I wouldn't feel comfortable saying yes or no to that at the moment. Secondly, we have seen a stark decrease in the levels of nitrogen in Thurrock as well. The levels that are set by the regulations are quite high, and I've never hidden that. I believe we're nearly 50% below the required amounts. However, we have been working hard with our air quality strategy. Our air quality officer is an exceptional officer and someone that has driven this forward. That's one of the issues we've had in the past, is attracting a very good candidate for an air quality officer. I'm pleased that we're able to progress this with Essex County Council as well as Southend City Council. It will enable us to push forward with things like funding requests through DEFRA. Being an entire county working all together, it's much more likely that we will be successful in those attempts rather than localised Thurrock only projects. So I'm optimistic about the future. I do believe we will drive that down still, and we'll continue to see good levels. However, I don't have a crystal ball, and I can't tell you exactly what Dartford Crossing, Lower Thames Crossing, etc. would be able to, what that will produce.
Anyone else? Can I ask a couple of questions? So the report clearly is very Essex focused. It would be, but would we doing a bit more in depth into Thurrock, particularly some of the areas of Thurrock around Tilbury, for example, where air quality, I know I'm not just talking about the dust here, but air quality. I'll come to the dust in a minute. And the second part of my question is, how is the air quality strategy affecting council policy? I'm talking about things like public transport, our own buildings, our own waste management, our own vehicles, and how we're working with local industries as well. A lot there.
In terms of how the strategy will implement across the council and affect other parts of the policies, once we adopt this strategy, it can then be considered by officers. It will be a public document at that stage, and I am certain things like the transport delivery strategy that would reference air quality, and I'm within housing and regeneration. I don't want to answer for my colleague, but I'm certain that things like planning, etc., also take in consideration all of the effects on the environment. Could you repeat your first question? Sorry, Chair.
I think the first question was about.
I recall now, the moment you started to speak, so apologies. In terms of localisation of this strategy, the whole purpose of the strategy is to enable us to take what we feel in Thurrock as relevant, and we will create our own action plan from off the back of that strategy. That action plan will be very much localised to the area, and what you'll see is specific targets for us within that action plan for our own residents. The strategy is designed to be wide-reaching because it has to affect the whole of Essex. It's up to officers within the council and members to create that action plan that is good for our residents and achievable for our council.
Thank you. Rob?
I don't know if I'm allowed to ask questions like this, but I'll try. Targets I get, Mike. I'm just wondering, is it in there or have we yet to do the work around what the outcomes might be that we're wanting to achieve? So for me, it's about saying if we apply this strategy then 5-10 years time, health-wise, there's a reduction in COPD, there's a reduction in a whole, through different movements, transport, reduction in improved in physical activity, things like, which links to the air quality. So I'm wondering, have we done the work yet? Which we're doing the JSNA, Joint Street Needs Assessments, on the agenda today. Harpel knows my views. We have a new Director of Public Health starting in next week. Around kind of that overarching picture is the JSNA, but there may be a needs assessment around air quality and time, which actually links it to the actual health outcomes for COPD, for a range of other infections and conditions. And are we looking at those outcome measures at this stage? Is that down the line yet?
That's down the line, but it's something that my officers are already working with public health on. So they already discussed issues surrounding where we're going to go with the strategy in preparation for the strategy being approved. It's been a long process with Essex as well to get the strategy in the right place. Like I said earlier, chief execs across Essex have agreed that the strategy could move forward, and I foresee the action plan pulling together exactly those data sets that you mentioned. With an action plan, you have to have an outcome focused plan. Otherwise, it's just a number of statements on a page. So really, we do need to make sure that baseline data is captured, and then we can progress over time periods of 5 to 10 years, as described by yourself.
Gloria.
Thank you, Chair. I think from my perspective, I think air quality knows no boundary because it impacts different geographies and obviously it's ambient, so it will require joint partnership working, not just the public sector but the private sector as well, because it impacts on, it's about emissions, and we talked, I know LTC and so on was mentioned, so the level of traffic, if you like, and the network that comes through Essex, obviously that in itself is a challenge for the borough, because on the one hand we're encouraging economic growth, on the other hand, the kind of sustainable travel and transport and all those things need to be considered. So I think the action plan will really need to look at the role that the different partners play in minimising air quality, and it's also about the kind of contributing factors to air quality as a result of that. So the activities that take place in the boroughs that contribute to air quality. So it's actually a quite a big agenda, and it's not just a local authority problem, but it's a public and private sector matter.
Thank you for that. Very good points. Though I want to come back to one of my favourite subjects, which is the dust in Tilbury. I know it's not quite air quality, but they're very connected. Are you in a position to give us an update on where we are with that?
Certainly, Chair. I was present at the Place Overview and Scrutiny Committee, where it was discussed with councillors and members of that committee around a methodology of trying to reduce the dust in Tilbury. It was agreed that I was to meet with various different parties that are included in the issues down in Tilbury, which included the Residents' Forum, the Environment Agency, the Port Authority, the companies that work down there, as well as the Port Health Authority. I'm pleased to say that I've met with the community leaders there of the forum, so I've met them and I'm going to speak at their community forum at the end of the month as well, because the level of engagement with them I want to maintain. I've also been speaking with the Environment Agency, and I was present at a meeting with the Environment Agency, the companies and the Port Authority to discuss dust management. I have raised my concerns with them and informed them that I will be going from organisation to organisation, collecting the information that I require, with the desired outcome of bringing all parties together in one meeting to establish a solution to the issues. I hope for that to be concluded by the end of the year, but as all know, I've not put a timetable on it just yet because I've still got to talk formally to all of the firms that are involved, so it may take me a little bit of time. But that was the decision made by the Place Overview and Scrutiny Committee. I will be giving exactly the same update to Place ONS as well, and I will progress it, keeping yourself, Chair, as well as the Chair of Place ONS informed, as I met with you only a couple of weeks ago.
Thank you, Mike. Okay, unless there's any... All right. Councillor Rigby?
Thank you, Chair. Thank you. If I could just go back to Rob's point earlier regarding the action plan and reviewing data of COPD, asthma, etc. It's going to be quite difficult to track because it's sort of multifactorial. Those diseases aren't directly... I mean, air quality has a link, but there are going to be other factors involved. Not least is the indoor pollution. I know that's going to be very difficult for you to track, but can you somehow manage that on like council-run properties? Is there any way of assessing that or increasing or improving, you know, indoor air pollution as well, which has quite a big link on asthma and other respiratory diseases?
I think it would be sensible for the group that come together to set the action plan to take all factors into consideration, really. You're quite right, it is very difficult to link one source of issue with health concerns, and that has been historically the problem that we've faced, having that direct link. However, I don't think anyone's naive to believe it doesn't have any effect, and therefore any meeting of the minds in relation to the action plan should be taking everything into consideration, and any data that we are able to capture from such things as housing surveys, etc., that information is inside the council and therefore should be utilised where appropriate.
Okay, if there's no other questions, shall I move to the recommendation? There
is no recommendation, Chair. It's an information update only.
It is recommended that the board members note the content of this report.
Yeah.
Noted. Okay, if I move on to... Thank you, Mike, for that. If I move on to item 9, LIDAR report, I always pronounced that incorrectly, so I apologise. We have the papers are on page 111 of today's papers. We have 20 minutes for this, 10 minutes presentation, 10 minutes questions. If I just ask Andrew Graham to present the item, please.
Thank you, Chair. So I'm here today to go through the Southend Essex and Thurrock Learning from Lives and Death, otherwise known as LEADER, annual report for the 24-25 period. So that goes from the 1st of April 2024 to the 31st of March 2025. LEADER is a programme that reviews the lives, the deaths and the care and support that people had throughout their life and at their death for people with a learning disability and or autistic people. It's now a programme that's for people aged 18 and over, so it's now an adults only programme, although we do link in with the child death oversight panels as well to understand learning that comes up in children, but none of that learning will be reflected in this report. Every year we bring the LEADER annual report to show the learning, the trends, and also give an update on the achievements of the 3 integrated care boards and the Southend, Essex and Thurrock local authorities, as well as the Transforming Care partnerships and the changes already being seen. This report at a glance kind of highlights that respiratory conditions remain the leading primary cause of death across all ages and all areas. This has been followed by cardiac or circulatory issues, and then cancer, and then sepsis, which is a common trend particularly for the east of England. You may have seen a couple of weeks ago the National Leader report was published where cancer was the #1 cause of death, but in the east of England for a number of years each area has had respiratory conditions as the leading cause of death, and it remains the leading cause of death for us in our local Southend, Essex and Thurrock report. We're seeing that more people than the general population continue to die in acute settings, and there is limited use of hospice care. And families of those who do die in the community experience a lack of bereavement services available outside of hospital and hospice settings in most areas. We've had some really positive findings, so we found that there's more positive practice in leader reviews. There are examples of positive practice in 101 out of the 135 completed reviews, which works out about 75%. When we came to see you last year, we said that we had 50% of positive practice captured in leader reviews, so that's something that's really positive. Although we do think that we're still getting underreporting of deaths across all minority groups in comparison to the Essex population data from the 2021 census. From a programme overview, we provide key performance indicators to NHS England, and against our data for March 2025, our completions of leader reviews within a 6 months rolling period was 88%. This is increased on last reporting and shows an improvement. And although that is below the target the NHS sets of 100%, it's important to note that across England, completions within the rolling 6 months period of notifications is 38%. And for the East of England region, it's 35%. Therefore, we're still well outperforming the national and regional average. We've also launched the 3-year Leader Deliverable Plan last April. The first year of the plan was reflected in the report, and we continue into the second year now. But one of the highlights of that plan from the first year was the establishment of Southend, Essex and Thurrock Leader Champions across all partners, and the successes for each year of the plan will be in each leader report. Regarding notifications, we had the most notifications we've ever had. We had the deaths of 127 adults with learning disability and or autism that were notified to us between April 2024 and March 2025. On one of the slide packs I've given, there's a number of notifications trend, and what you can see is there's peaks, and what we're noticing now is there are peaks both at the winter now and in the summer months. We've also given a breakdown within the summary slides that are within the pack of the different people that notify to Leader, because we do not automatically get notified of the deaths of adults in our community with learning disability and or autistic people. Most of our notifications come from learning disability liaison nurses or social workers or other health professionals. So we are working hard to try and get more notifications so we can review the life and the death of people with a learning disability and autistic people to understand all of the learning wherever possible. The trends for the average age at death, we've seen a rise from 59.3 years in 2023 to 2024 to 59.56 years in 24 to 25. Within the cover report that we've given, we've shown an image which shows that in 2019-2020 Leader Annual Report, the average age at death was 57. Then during the COVID period, the 2020 to 2021 Leader Annual Report, it went up to 64. And then in 2021 to 2022, it went up to 65.5. And then in 2022 to 2023, it went down to 57. And then in the 23-24 period, it went up to 59.3. And then in the 24-25 year, which I'm here to talk to you about today, it went up to 59.56. The reason why we wanted to show this is because one of the reasons we feel that we're rebuilding that medium average age at the moment is because we lost some of our oldest members of our population during the COVID period. So it started at 57, obviously it rose and then it ended at 57. So we believe that although there's a slow build, it's positive signs that the median average age is going up. With regards to place-by death, we found that in different areas across Essex, more people are starting to die in places of their choosing other than hospitals and acute settings, but acute settings is the primary place where people are dying. We know that a lot of work is going on across Southend, Essex and Thurrock regarding end of life and also to support people to die in a place of their choosing, but just wanted to flag it because there is some improvement in some areas. With regards to primary cause of death and complete reviews, as I said earlier on, respiratory illness is the leading cause of death for the area, which is in contrast to what we'd expect to see from the general population, where we'd expect dementia and Alzheimer's to be the leading cause of death. We said our second leading cause of death was cancers and circulatory, and obviously that's not reflected in the general population either. Their secondary cause of death is ischemic heart diseases, and then their third is respiratory. So the information that we have continues to inform the work that we're trying to take forward. Obviously, respiratory illness has been a focus for a long period of time, but that will be picked up again in the recommendations that I come to at the end. With regards to annual health checks and health action plans more generally, across the whole of Southend, Essex and Thurrock, we found that 100 people out of 135 complete reviews, 74% of them had their annual health check. Out of that 135, out of those 100 people, 24 of those people had documented evidence of a health action plan, while 23 had a health action plan coded in their records without visible evidence. This is an improvement on the findings from the previous year, and obviously this only represents the annual health check performance in regards to the people that we review, but they are some of the most vulnerable people. In regards to consistent and emerging themes, we've seen that weight management is something that has come up. We know that the 3 local authorities across Southend, Essex and Thurrock do have a weight management focus. So we've started capturing body mass index. We've given some data in the slides which shows that there was a significant number of people that were healthy weight or underweight, but we think this might be erroneous, and we think it could be down to when we're capturing it. So if people have had significant weight loss because they've been very ill, that might look like their weight might have been quite healthy, whereas for most of their life it could have been very different. So we're trying to do some more work on that on how we capture BMI. We've seen that DNA CPRs, or do not attempt pulmonary resuscitation, there's been improvements there with the number we've been seeing used correctly. That's similar with mental capacity assessments as well. Vaccinations, we've captured where people have had their COVID vaccination and then pneumococcal vaccinations as well as their flu vaccination. So that's in the slide decks for people who would like to see that. We think regards to STOMP and antidepressant use, STOMP is to stop over-medicating people with a learning disability and or autistic people with psychotropic drugs. There's a lot of work being going on across the system to help transition people off of psychotropic drugs if they don't have a serious mental illness. So there's some work going on there, and there's some data reflected. We've listed as well, we've got a companion document around Thurrock-specific insights, and we do this in the slide deck. We've done this from completed reviews, and this lists things such as in Thurrock 7 reviews were completed, 4 were initial reviews and 3 were focused. Reviews consisted of 3 females and 4 males with an average age of 59. All 7 individuals in the reviews identified as white British. 4 received their COVID vaccination, 4 received their flu vaccination, 1 their pneumococcal vaccine. All 7 had their learning disability annual health check, of which 3 had evidence of receiving a health action plan. and one individual had an health action plan coded on their record, but this was not seen or evidence. And then we also list items such as DNA CPRs and place of deaths. And in Thurrock, 4 people died in Basildon Hospital, but 3 died in their own home. So that's a positive sign. We've also listed some really good practice that's come across as well in the slide decks. We've identified risks to reducing health inequalities. I won't go through them now because I know I'm short on time, but there were 6 risks. This was written as of April 2025, so some of the risks now may be reduced because things such as the long-term plan has been published and the National Leader Report for Deaths in 2023 has been published, which were 2 of those items listed. But we've got 5 recommendations for this year, which is to cover pieces of work on end-of-life planning and ageing well. We're looking at cancer screening, because really important, because nationally cancers has been rising in national reports, and we're not seeing that reflected in Essex, so we want to make sure that we link in with groups doing cancer screening work across Southend, Essex and Thurrock. We also want to develop a respiratory health checklist, because we know there's been a lot of respiratory health work done, especially postural, dentistry. There's lots of work with the speech and language teams. There's been conferences that have been held, but want to kind of tie that all together to help people look at risk factors. And then people with a learning disability and autistic people need to be supported to maintain a healthy body weight. So we want to link in with the public health teams across Essex and support that movement. And then also we want learning disability annual health checks need to improve their quality and impact. So that's our 5th recommendation. And we want to see a step towards ensuring that is to see physical health action plan documents that are referenced on file so that we know the advice that was given and how it was tracked over time.
Okay, thank you, Andrew, for that. If you have any questions, so I'll start with Rob.
Yes, so can I say thank you for the report? I skimmed through it. I skimmed through it last night. It's really interesting. So really interesting information. 3 things probably in my head. So I only looked at it last night. So I looked at it thinking the stuff I need to take away internally to discuss. So there's 3 things. They link to your recommendation, those 5 areas of recommendation. So the first one around, well, let's do healthy weight first. So we know now when the JSNA comes out, we know we have a healthy weight management problem across our population in Thurrock, where we're an outlier compared to many places. So I'm interested in probably taking away working with you and the public health team, Harper, when a discussion about how are we, because we've got a health weight strategy, which is looking at how we're targeting our healthy lifestyles work and that. But do we need to do some more targeted work with this community in particular? There's one thing which I'm going to need to think about, like your view on. The second one is around this focusing on end-of-life planning and ageing well. It still seems to be a significantly high proportion die in hospital, and we know that that's the one place you do not want to die. Generally, you do not want to die in hospital. And I'm just wondering whether we've done any analysis as to why that's still happening. So is it to do with kind of awareness, lack of awareness of other options? Is it to do with a lack of services, or is it to do with capacity to get into services? I'm really interested in. And then the third bit around, probably maybe looking left, I had a conversation with somebody else earlier on today about health checks for a different cohort of the population in Thurrock. I'm just wondering whose responsibility is it? Does it sit with NELF to do the health checks for this community or not? Because what are the action we're going to take to try and improve the annual health check attrition rate? Is that okay?
So just on the first point with regards to healthy weight, one of the things that we're looking to do is to link that to the annual health check and the health action plan, particularly for the learning disability community, because that is something where people are weighed on their annual health check typically, and it is an opportunity to check it year on year and give advice and link into services that might be available to them, or some information, advice and guidance that could support them. And we do know nationally it's a healthy weight is definitely something for the learning disability community in particular people are looking at. I think end of life planning sometimes is because there often isn't frank conversations always seen in reviews. So like we're doing a piece of work in Leader at the moment to try and, with a task and finish group, to try and get some of the key terms and explain what they mean. So like there's often a conflation with palliative and end of life. So someone might be palliative for a long period of time, but then it might be different. Professionals might either assume that those conversations regarding end of life have already happened, and there may or may not have been a peace plan or other accompanying document, or they're very sensitive to the conversations that happen. And our view in Leader is that the earlier end of life conversations can happen and aging well, and people start to think about what they want for their future, will help to reduce the kind of the kind of challenges around those conversations, because when you're very ill, making those decisions, thinking about that is much more challenging, can be very distressing. So we know that there's the Victorian Stewart toolkit that's been released, I think it was either earlier this year or early last year, and that's specifically targeted at learning disability, and some groups in Essex are using that because it's got images and that to help. But we want to link in as well with the integrated care boards. They have Macmillan End of Life leads as well, and they're doing some really great work around end of life, and they're supporting our end of life task and finish. So it is kind of a movement to destigmatise end of life conversations, and health checks are carried out by primary care. So we link in with our primary care leads in the integrated care boards regarding that, and then they work with the primary care networks and the GPs regarding quality and delivery of those checks. So we know that in particular in Direct they've looked at whether or not they're going to look at accreditations and how they're going to support people to learn more around how they can make the annual health checks and health action plans impactful. So that's within the GP surgeries, and it's often one of the staff at the GP surgeries that would do that, not NELF.
Margaret?
Thank you. Thank you, Andrew. There's an awful lot of data there, and there's an awful lot of text explaining this. I've got a couple of questions. My first one is, as a result of having all the data and researching and seeing the trends and such like, what's changing for people with learning disability or people with autism? And is there a strategy through the work around Leader to really be able to work with, particularly with adults with learning disability who are finding it very challenging to engage either with health providers or with other services?
So I think what's changing is that when I first joined Leader about 2.5 years ago, one of the main issues that were coming up, and it was a significant cause of death, was things like constipation. And we've seen the change that people have effectively, much more effectively been able to manage that. We're also seeing that there's a lot of work being done across the system regarding training such as Oliver McGowan and other equivalent training to kind of understand the learning disability and autistic people cohort. When it comes to linking into plans and strategies, local authorities and the integrated care boards ask us to, help input into data that they have, and we share the data with local authorities and with integrated care boards who make up part of our steering group. I think sometimes year on year we have differences and changes. Like last year we had a lot more men that we reviewed than women, and now it's gone back to what we would expect to be more 50-50. So, because it's a small cohort of data in comparison to something like the national report, it is liable for change. So last year I came with a warning around sepsis, and sepsis has reduced, like in comparison to what it was last year. So we are seeing that trends regarding when people are getting ill is changing. There are more peaks in summer, is something that's coming up. And we're going to be looking at a piece around to kind of review our data for the last 3 summers and understand if there's any correlation between that. But I think there is a lot of data, but trying to understand what's the most pivotal items that we can impact on is kind of what we try to do every year. And I think maybe something, if the Leader annual reports were 5 yearly, it'd be a bigger group of data to be able to track what has changed over time. We have a 3-year deliverable plan, which is to make the overall changes. So the first year of the plan was around annual health checks, Leader champions, to work with Stomp, and also it was so those were the main priorities we took forward. This year it's about raising much more awareness of with autistic people and autistic communities, because we don't understand a lot of the challenges of people who are autistic without a learning disability. We're still growing our knowledge around that. We have much more knowledge around learning disability and autism, but we don't have a formalised strategy from LEADER per se. The current scenario is that the 3 ICBs have delegated the responsibility of LEADER to the hosted team, which I sit in. So that's kind of we would then feed into any strategies that were available. We don't have one ourselves.
Okay, I've got a number of questions. If I go Rob, Linda, and Gloria.
Yeah, can I just come back on that point? So just for the board to be aware, in Thurrock we are currently undertaking an adult autism and neurodiversity strategy, which is due to come to this board in, I think it's February, and we'll have a draft of it by the end of the year. So I think it would be important to check in that strategy. Margaret makes a good point. I think we need to check in that report that we do address. It's going to address the standard bits, but it's going to be a bit broader, but it is around employment, quality of life. Access to health services is always a significant issue, and social activity and housing. You know, they're the broad themed areas. So I think it's important that we do address that within the strategy. So I'll make sure that does get picked up in that work that's ongoing at the moment.
Councillor Warren.
Thank you. And Rob, you've kind of answered part of the question that I was going to ask, because a lot of these primary causes of death, one can quite link to the other, you know, and if they are not leading a healthy lifestyle, then they're more likely to get the respiratory and the cardiac arrest, you know, as a cause of death. So it's almost like we have a duty as a council to make sure that our services are meeting the needs of these people. Because I kind of think if I want to go for a walk, I can just put on my coat, go for a walk, go for a run, get on a bus, go swimming, whatever. These people rely on services to be able to keep them fit and healthy and improve their life chances. So I kind of feel like some of this, I'd like to see the data, I guess, on has there been any increase in their life expectancy? And if so, is it where the services are easily available for these people? Because I kind of feel like I've got a duty to say, actually, let's make sure we've got the wraparound to give these people their best chances. And if we're not doing that, then we're failing. So I think it's I'd like to see that in future we're able to measure, you know, to get these down because of the services that we absolutely put in place. So, and hopefully that will be feeding into the strategy, and sure across Essex others are doing exactly that same piece of work. You know, we can't be, whilst I'm the leader of Thurrock Council, I want to make sure that the leaders of other councils are taking that same duty of care to these people, because we can help themselves. Often these people can't help themselves, and you will sit and eat. If I'm indoors, I'll easily eat far more stuff than I'm supposed to. I'll be in that cupboard before I know it. You know, so it's about making sure they've got access to services and things outside of the home that leads to healthy lifestyles.
I think it's a really good point. So again, not necessarily here, but I think it's these questions that these papers stimulate. So we're in the hospital yesterday, and I saw 2 people, 2 adults with a learning disability in the hospital, obviously there. I suppose I don't know what the situation is about, how the hospitals support, how the staff support. Are they trained to know how to look after people with a learning disability? If they're in a ward, in a bed-based setting, how are they trained to kind of make sure that their kind of dietary needs are met, etc. I'm not suggesting we need that detail here, but they're the questions which get stimulated, because they are the things we need the answers to then be able to turn the dial on that data that Lynn's just been addressing. So I don't know whether Chair just want to come in.
Thank you. So I think the answer to that question is there is a number of programmes of work that we do within the organisation, However, as I read through this, it made me curious about whether we're actually doing enough and whether there's more that we can do. So if I may, can I follow on with that response with a couple of questions of my own? I'll come back to me. Sorry, I hadn't realised your hand was.
I'll come back to Gloria if that's okay. I don't mean to be disrespectful. I'll come back to Gloria. Cherry, this is a great opportunity, and thank you for coming to the meeting. Welcome. I didn't give you the opportunity to say that today.
Thank you. So, excellent report, Andrew. I really enjoyed it and very thought-provoking. So, as I went through and listening to some of what you were describing, there were a few things that I was curious about. So, one of the things that I think you said or I read was around cause of death, being respiratory, being the sort of primary cause of death for this particular group, and I wasn't sure whether that was in comparison to general population or whether it was in relation to in the East, and I just wondered about. I'm just curious about that, because if it's specific, if we're comparing like with like and it's specific to the East, I just wondered about that. If it's related to general population, a comparison with general population, again I'm curious, and I'm looking at some of the recommendations. I wondered if there is a correlation with the cause of death with perhaps low vaccination uptake. So that was just I wondered if that was something that's come out of the work that you've done. That was one question. I don't know if you want to ask that, but I've got some more.
Yeah, so when I was saying about the respiratory illness, I meant for people with a learning disability and autistic people that are reviewed by a leader, nationally the picture has always been cancers or circulatory, but in Essex, Southern Essex and Thurrock, it's been respiratory for a long time, and that's mirrored across the whole East of England
learning
region.
Disability nationally, but locally it's more.
Yeah, so
right,
nationally they're seeing cancers as their number one, but in the East of England region, all of my equivalents over there, I haven't seen their current reports, but in previous years it's been respiratory.
Yeah. So that's interesting, and I wonder what that's telling us, whether or not, and obviously it is highlighting some of the points that were made earlier about access to healthcare, whether it is about vaccination. My second question was then, I was interested in the ethnicity notification set, and I think what I was thinking when I looked at that was that isn't necessarily representative of the population we serve. So why do we have a lower? Why is the data suggesting lower notification for certain ethnic groups that is slightly out of kilter with the ethnicity of the population?
Yeah, I think the honest answer is in previous reports we thought it's around finding people where they are so that their deaths are notified, but we're also linking in with Hertfordshire and West Essex ICB. They're doing a global majority piece that's in response to the NHS Race Observatory report on people from an ethnic minority background who die young, and that's based on previous leader national data, and it's looking at the inequalities that they face based on their background, not just their learning disability, to understand if there's any inequalities we're seeing. But I don't know, but we're trying to find out.
Okay, no, it's really, really interesting. Just my final point on the recommendations were what I reflected on. And you don't have to answer, it's just a reflection, is what more do we in the acute sector need to do to kind of help and support this. Just an observation, reflection.
Is that something you can give some feedback on?
I think it's from one of the good things about Oliver McGowan training, or the equivalent, is it's supposed to upskill staff to understand the needs of someone with a learning disability and autistic people. We know that learning disability nurses have to prioritise people that are in hospital and they can't see everyone, so it's about making every contact count, I think, on the wards, and understanding reasonable adjustments for people and being a champion for those people.
I know from my day. Cherry, and I'll come back to Gloria.
Just very quickly, just to say that the Oliver McGowan training is mandatory, part of our mandatory training for all staff. I've done mine.
That's fantastic news. Sorry, Gloria.
No problem. I think much of the points have been highlighted, but I'd be interested to understand in terms of giving, I mean, it's a fantastic report, there's a lot of information there, but what I didn't pick up was, you know, accessibility to these services and the inequalities and disparities. So if you're, I know certainly in Thurrock, and if you look at the different communities that we serve in Grays and Tilbury, etc., there will be people who English is not their first language. How do they access this service? You know, what is the kind of support they get just to actually communicate what they need, never mind actually accessing a service that they need. And secondly, it certainly highlights that mental health, exercise, diet, and for me, the family wraparound, it's not just the service. These people will have families, they'll have friends. How is that looked at? So it's a holistic approach to an individual's life, not just service providers will come and go. If family is also there surrounding that individual, because there will be cultural needs as well. So I think I would love to see more of that, because as has been highlighted by a person over there, that the community is not representative of the community that we serve. So I just wanted to highlight that.
Thank you for that. I guess that's somewhere we can go and look at, isn't it? I guess in terms of our own strategy, we need to look at it as well. It's still quite shocking, though. Oh, sorry if I missed something. Sorry, Councillor Rigby.
Thank you, Chair. Sorry. Thank you for the report. Yes, Cherry did mention as well the respiratory diseases. They are quite shocking, and the number of pneumococcal vaccines very low. I'm not sure whether they can be given at the same time as the COVID and flu vaccine. I know certain vaccines can't be given at the same time, but if it could be, then could that not be given at the same time so that they're covered for the three? I mean, that would obviously be a medical thing as to whether there's a conflict, you know, whether they could be administered at the same time. And also things like aspiration pneumonia, they are treatable. So is that just not being detected early enough? Are they not getting on the antibiotics and treatment earlier? So I'm just wondering what your respiration project that you're doing is going to cover, really.
So the pneumococcal vaccine is something that we've looked at because it protects against community-acquired pneumonia, and we've worked with MSc ICB to get learning disability put in the criteria regarding the Easy Read that they've produced. I think there's been conflicting items from the NHS regarding pneumococcal and its use for learning disability. The Green Book doesn't reflect learning disability, but their website says it's one of the vulnerabilities that could have it. So I think sometimes primary care colleagues are not sure whether or not they can have it, but there is an age over 65 that they are able to have it. So it is something that could make a difference. I can't speak to whether or not it can be given at the same time. I think that's, as you say, a medical decision. With aspiration pneumonia, it is kind of those risk factors, that long-term postural deterioration. You know, dentistry is something I learned a year or two ago is a real